Hi again, everybody. We're going to talk about a few more neonatal infections. We're going to talk here about congenital varicella, which has sort of two distinct manifestations depending on when mom contracts the varicella, if it's early in the pregnancy or later in the pregnancy. There's the fetal varicella syndrome and the neonatal varicella syndrome. There's group B strep infection. Remember, group B strep, #1 cause of neonatal sepsis. And then some special considerations including infants born to mothers with HIV, infants born to mothers with hepatitis B, and infants born to mothers with active gonorrhea or chlamydia. So congenital varicella is an infection with the varicella zoster virus. It's a commonly known virus that causes chicken pox, particularly in kids, but it can happen in adults too. And then ultimately, that virus never completely goes away. It stays along in the nerve roots, and it can cause shingles in older people and adults, especially in the elderly, if there's ever an immune disruption, particularly. That's why it's called varicella zoster virus. It causes varicella and it causes zoster, which is shingles. So most of the population is immune to varicella zoster virus because they got chickenpox when they were younger. But a lot of people are also immune now because they received a vaccination, and that vaccination only came out relatively recently. I think when I was a kid, I got vaccination. I don't think I ever got chickenpox, and I think I was one of the first bunch that were in that crowd. I think that was in the mid '90s or so. But either way, if you've gotten the vaccination or if you've had chickenpox, it's highly unlikely for these people to contract VZV again, to contract chickenpox. So, because of that, there are a large proportion of women in the population who will not give birth to baby with any kind of congenital varicella problem. However, if the mother has never had chickenpox and she's never had the vaccination, then she is at risk. And this is similar to how the CMV disease works. The fetal problems occur when the mother contracts the virus for the first time, and this leaves the fetal tissue exposed until mom can produce enough antibodies. Those antibodies are protective to baby too. And so that's why if mom has been affected, and she passes those, in the past, she passes those pre-made antibodies onto baby, and baby will be safe too. Now, there's something unique with congenital varicella in that we see two kind of distinct syndromes. You could really even break it down into three, but there's really two unique syndromes that you see depending on when the mother contracted the chickenpox. So if the mother contracted the virus during the week 7 to 28 of gestation, it can lead to fetal varicella syndrome, which affects the CNS and it affects musculoskeletal development. In many cases, if it's earlier than this, it'll lead to can lead to this, but it can also lead to just spontaneous abortion. So if it's early on in the pregnancy, it's going to cause problems with CNS musculoskeletal development. If the mother contracts the chickenpox in the month of delivery or like 2 weeks prior to delivery, it can lead to neonatal varicella syndrome. And this involves that typical rash that you see on anybody else with chickenpox. Now, there is a small window period where if the mother is ill with chickenpox during that period, it looks really bad for the baby. So if the mother's infection starts 5 days prior to or 2 days after delivery, then she was probably infected at a critical time that it's going to cause the baby to be really, really, really ill, because the baby will have absolutely no immune protection against varicella. So if it's, I'm trying to explain this clearly. If it's a few weeks prior to delivery, the baby might have this rash, but the baby tends to be okay because the baby will have gotten some of those antibodies. But if it's right before delivery, then the baby doesn't have any antibodies, but they have varicella, and so that is a big, big, big problem. And so those babies will be quite ill. So I want to break these up now. So if the mother is infected with varicella zoster virus, usually in that 7 to 28 weeks of gestation, so sometime during pregnancy, the baby will be born stable. The baby will not have chicken pox, since the baby has long since acquired mom's antibodies, but there will likely be stigma from the infection that occurred in utero. And so these manifestations include limb hypoplasia, particularly of the upper extremity, the clavicle, the scapula. There can be rib anomalies, scoliosis, umbilical hernia, microcephaly, cortical atrophy, seizures, chorioretinitis, microphthalmia, hypoplasia of the optic disc. This very unique cicatricial cutaneous scarring. This is in a dermatomal distribution. I'll show you a picture of this. And so in order to diagnose this, and you're already going to have an idea that you're going to be looking this way, and you're going to be having to do these VZV titers, because there is a history of mom getting infected with something that looked like chickenpox. You'll get these VZV titers in the neonate, and positive titers will indicate that the baby has been exposed to the virus, and also will probably have antibodies acquired from mom. And so in this case, this can also be called VZV embryopathy. Fetal varicella syndrome is diagnosed clinically if you consider the mother's history of VZV infection, chickenpox, and the clinical symptoms. But technically, you should get VZV titers. That will indicate that the baby's been exposed to the virus. So it can be diagnosed clinically, but technically it should be diagnosed laboratorically. The treatment is supportive. There's really no active viral infection going on, so no medication is really going to help. 30% of these babies die in the first month of life, but some of them do go on to live. And so here's an example of that cicatricial scarring, and you can also see hypoplasia of the upper extremity here. Okay, now on the other hand, neonatal varicella syndrome is also a maternal infection with VZV, but it happens within this risk period of 5 days before and 2 days after delivery. And an infection during this time means that the baby was exposed to the virus, but was not in utero long enough to get the maternal antibodies. So now the baby has the virus circulating in its blood, but has no antibodies and no way to fight it off. And remember, the baby's immune system is not developed. So this is a big, big, big problem. The baby's going to have a progressive vesicular rash. The baby will also be ill-appearing, and there'll be temperature instability. The diagnosis is typically clinical. You got mom with chickenpox, gives birth to baby with chickenpox. So usually you can expect this. The treatment is going to be administration of varicella zoster immune globulin. That's the best treatment. However, the problem is now that we don't have varicella zoster immune globulin in the United States readily available. So I believe now you can use acyclovir to treat the baby as well. But the best treatment would be varicella zoster immune globulin, and that's going to take care of the virus. That's basically a synthetic antibody. And it just looks like little baby with chickenpox. It's pretty easy to see because you see chickenpox in kids all the time. Got all these different vesicles of various stages. Okay, so moving on to the GBS infection, 10 to 30% of women who are of childbearing age carry group E strep, which is strep A galactea. It's part of their normal vaginal flora. This is not a sexually transmitted agent. This is a normal bacteria. It doesn't affect the woman at all. And most of these women, this 10 to 30% of women, also carry circulating IgG antibodies against group B strep, which can be passed on to the fetus to prevent any kind of problem. The problem crowd is the women who carry GBS in their vaginal flora but don't have the circulating anti-GBS antibodies. They cannot protect their babies by passing on their antibodies. So these babies don't have the passive immunity against group B strep, even though they will be exposed in the birth canal because mom has group B strep in her flora. So it is for this reason that we culture all women at their third trimester visit, 35 to 37 weeks of gestation. We get a rectal and vaginal culture for group B strep, and if it's positive, when they go into labor, we'll treat them with IV antibiotics, typically penicillin, during the labor and delivery process, and this will help reduce the chance of neonatal infection. We can give penicillin G, 2.5 to 3 mega units every 4 hours until delivery. We can also use cefazolin. I think that's, you start with 2 grams IV and then give 1 gram every 8 hours until delivery. There's lots of different drugs that can be used, but the drug of choice is penicillin. Now, in the event that the baby is exposed to group B strep and does not have appropriate circulating antibodies from mom, then that is the case when infection can occur. And these sequelae can happen early, or they can happen later, or I guess they could possibly happen both. The risk factors for group B strep infection is the baby was delivered prematurely, if the rupture of membranes lasted 18 hours before delivery, if the mom is younger, if the mom has a history of delivering a baby who went on to develop group B strep infection, obviously, or if the mother is of African American or Hispanic race in the U.S. So early onset neonatal group B strep infection typically will occur within 48 hours of birth, so you should be able to notice this before you discharge the baby. And the signs are basically everything consistent with sepsis. So apnea, ill-appearing, irritable, won't want to feed, temperature instability. Signs consistent with shock are even possible if it goes on far enough. So labs, what can you do? Well, of course, if the baby has apnea or signs of deoxygenation, you may want to get a chest X-ray. This will look like this will look like as if the baby didn't have enough surfactant. And so you may think that, but in the setting of what you have here, baby born to mom with group B strep and didn't get treatment, then you should suspect that this is a group B strep infection. So the chest X-ray is diffuse homogeneous ground glass infiltrates. The CBC will show a leukopenia with left shift. Remember, you can't babies with infections with sepsis, they don't always look the same as adults, so you kind of have to throw your assumptions out the window. Blood culture and CSF culture, of course, will be positive. So diagnosis may be inconclusive until the first cultures return, because you can't really make the diagnosis on the chest X-ray. You can't make it on the CBC. You really can't make a for sure diagnosis of GBS infection based on the symptoms alone. So what you're going to be doing initially for treatment is to just say, all right, we've got a baby who has got something that looks like bacteremia, sepsis, and so we are going to treat this baby with antibiotics that cover pretty much everything. So we'll treat the baby with ampicillin and either gentamicin or cefotaxime. And then when the labs return confirming GBS, you can switch the drugs to penicillin G, which would be the drug of choice for group B strep. Of course, you should also be looking at other routes, possibly neonatal herpes if the mother had that. Always keep your differential broad. But in a mother who has group B strep in her vaginal flora and was not treated properly, this is what you're primarily going to be looking at. There's also late onset GBS infection. That should actually say 7 days to 7 days to 4 months, median at 1 month of age. Usually these will be babies that are ill-appearing on presentation, and what the Group E strep can cause is usually meningitis or pneumonia, but there can be other focal infections like cellulitis, acute otitis media, conjunctivitis, and so forth. Again here, if the baby has pneumonia, it will be a diffuse homogeneous ground glass infiltrate. If you have CVC, you may see a left shift. You're always going to be getting a CVC. You should never say if you get a CVC. If you get blood cultures and CSF cultures, those are going to be positive. So for diagnosis here, again, it can be inconclusive until the first cultures return, and so we treat this broad spectrum, ampicillin and either gentamicin or cefotaxime. When the labs return confirming GBS, then you can switch to penicillin G. Now, determining between gentamicin and cefotaxime may be important on step 3. I have seen a question that asked or that knocked you off if you chose one of these rather than the other. So what I'm going to say is if you do a spinal tap on a baby and the CSF demonstrates that there may be meningitis, regardless of whether or not you've had a culture, you should choose cefotaxime. Cefotaxime works better for meningitis. But otherwise, you can choose between the two. But if you suspect meningitis, you should use cefotaxime with ampicillin rather than gentamicin and ampicillin. Just my 2 cents. Okay, so some special consideration. We talked about infants born to mothers with HIV. So all mothers should be screened for HIV as part of their routine prenatal care. Regardless of their risk factors, all moms should be screened for HIV. The moms who are HIV positive should be starting to take zidovudine, if they aren't already, no later than 14 weeks of gestation. An elective cesarean section may reduce the risk of transmission, but only if it's performed before rupture of membrane. So if mom's water is broke and she's already in labor, a cesarean section is not going to help at all. It's not going to reduce the risk of transmission at all. But if she schedules an elective C-section and goes in and her water hasn't broken yet, it may reduce the transmission of HIV. After birth, the baby should be tested for HIV, regardless of results, whether it comes back negative or positive. Remember, the baby can't develop. It takes a while for a baby to develop antibodies. The baby should start taking zidovudine within 12 hours of birth, and the baby should take the zidovudine for 6 weeks. The baby should be retested for HIV after 2 months after birth, and then at 4 months after birth. And a negative HIV result at 4 months of birth reasonably excludes HIV diagnosis. If the mother was not on zidovudine during pregnancy, then the baby should be started on a double or triple antiretroviral regimen, including zidovudine. So you could add another drug, just make sure it's safe for children, for babies. So I'm trying to think back to my HIV antiretrovirals. You could use lamivudine probably. You could use tavarine. I can't remember all the ones that are pediatric safe, but just make sure you remember that if the mom was not on zidovudine during pregnancy, as she should have been, then the baby needs not only zidovudine, but a double or triple antiretroviral regimen. And then also this one gets tested a lot. If mom has HIV, absolutely no to breastfeeding. Sorry. Okay, babies born to mothers with hepatitis B. So all mothers, just like with HIV, all mothers will be screened for hepatitis B surface antigen, which denotes infection, as part of their routine prenatal care. And if the mother has hepatitis B surface antigen, then she should go on to get a full Hep B panel so you can know exactly what her status is. So in 95% of cases, the transmission occurs during delivery, and the risk of transmission is higher if mom is E antigen positive and E antibody negative. If she has high serum levels of hepatitis B core antibody, and if she has high serum levels of HBV DNA, that just means there's more virions circulating in the bloodstream, so her blood is more infectious. All infants that are born to mothers who are Hep B surface antigen positive should receive the HBV vaccine, just like all other babies. And they should also get the hepatitis B immune globulin within 24 hours of birth. That's going to give the baby immunoglobulins that will attack, for lack of a better word, attack any Hep B virions that got into its bloodstream. Unlike HIV, hepatitis B is not a contraindication to breastfeeding. Just make sure to assure the woman that it's important that if her nipple is bleeding, then you can't breastfeed while your nipple is bleeding. And most mothers don't want to breastfeed when the nipple is bleeding, but that's something worth mentioning there. But hepatitis B is not a contraindication for breastfeeding. Finally, infants born to mothers with gonorrhea or chlamydia. So both of these are STDs that should be tested for during routine prenatal screening. However, it is quite possible for a mother to be negative on prenatal screening and then acquire it during pregnancy, because you can still have sex when you're pregnant. So the neonate will acquire this infection while passing through the birth canal. Both of these can cause conjunctivitis. Gonococcal conjunctivitis, which is also known as ophthalmia neonatorum. This is a purulent and copious conjunctivitis. Chlamydial conjunctivitis is a little less dramatic, and it's more noted by redness in the eyes. Both are typically prevented by routine use of doxycycline ointment on all babies. If you want to learn more about conjunctivitis, I did a very long ophthalmology section that I'm really glad to be done with. C. trachomatis can also cause pneumonia, just like chlamydia pneumoniae. And this tends to have a subacute onset of wheezing, cough, especially that staccato coughing. It's kind of like kind of like almost like the baby's clearing its voice, but it sounds more like a baby cough. And then occasionally there may be a coexisting conjunctivitis, but notably here there's no fever. You can get a chest X-ray. It will usually show nothing but hyperinflation, maybe a few infiltrates. So you should get a rapid antigen detection test on any nasopharyngeal secretions, and then you treat these babies with oral erythromycin for 2 weeks. Neisseria can cause a disseminated disease of sepsis, arthritis, and meningitis. It's diagnosed with another RADT, treated with cefotaxime. We'll talk about this later when we go on to talk about meningitis. This is a very important cause of meningitis in babies. In addition to treating the neonate, you should also diagnose and treat mom. And so to do that, you'll get urethral and cervical swabs. Make sure you get endocervical swabs as well. You want to get all the way into the cervical, into the cervix, not just the outside, for chlamydia and gonorrhea. And if the mom comes back positive for chlamydia, you give her azithromycin. If she comes back positive for gonorrhea, then you'll give her ceftriaxone and azithromycin. Now, I got some questions a while back about if we do the swabs and she's positive for chlamydia and negative for gonorrhea, we give her azithromycin. But why not if we do the swabs and and she comes back positive for gonorrhea but definitively negative for chlamydia, why do we have to still treat her for chlamydia? Well, here is the answer. So is dual therapy for gonococcal infection recommended even if you have a negative chlamydia result? Because what we always learn is that if mom has gonorrhea, we treat her for chlamydia as well. But why do we have to treat her if she has a negative chlamydia result? This goes for everybody, not just moms. Why do we have to treat somebody if they have for chlamydia, if they have a negative chlamydia result? And this is the answer from the CDC. Dual therapy for gonococcal infections with ceftriaxone in a single intramuscular dose in combination with either azithromycin or doxycycline, independent of the patient's chlamydial infection status. Neisseria gonorrhea has the potential to develop resistance to the few antimicrobial therapies available. Dual therapy may hinder the development of antimicrobial resistant organisms. Finally, particularly in men, post-gonococcal urethritis can occur even in the absence of chlamydial infections. For all these reasons, dual therapy is preferred for all patients with gonorrhea, irrespective of chlamydia test results. So there you have it from the CDC. So even if you do a swab and they come back negative for chlamydia, if they have gonorrhea, you better be treating for chlamydia. That's what the CDC says. So hopefully you enjoyed this venereal diversion from neonatal diseases. If you have any questions, go ahead and write me up.